Kim Crawford.
Constellation.
Oh, that's
imports.
That's the importing.
All right. We are starting in 5, 4, 3, 2. Still loading. You are now live.
Cheers.
Hey, welcome to Wine Down Wednesday. Just want to do a shout out to one of our patients. She is one of the distributors, right?
Yep.
For Kim Crawford, and she has given us an abundance of wine for the next few Wine Down Wednesdays.
Yes.
And this one is the Kim Crawford Rosé, and all of our staff in here is drinking this, so this is not us.
Yeah.
That just drink all this.
Yeah,
so
I'm on water today because I'm going back to
she's
surgery
got
tonight.
surgery
so.
after this. The day
Yes.
is not over and it's not done. Today's topic has been the hush-hush one that we've kind of avoided for a little bit. But we're going to talk about vaginal rejuvenation and kind of labiaplasty because they are not the same. It gets a little bit confusing to patients.
Yeah. So I think step one is to kind of go over the anatomy of this area because so many patients will come in and say, I have a problem with my vagina, and they mean their labia minora, or they'll say my labia minora and they mean labia majora. So what are these areas?
Yeah. And I think the reason we've had a little uncomfortable talking about it because we do know there is a lot of controversy out there. Let's probably touch on that first because a lot of patients are petrified to talk about this. They're so ashamed and embarrassed when they come in, but they have reasons to want this done. And, you know, if, like you said the other week, it was great where you're like, if you don't understand this or know why it's a problem, just count yourself lucky. Yeah. And move on.
Because I find the people that are the most judgmental about people doing this surgery are people with completely normal vaginal anatomy who have never had the experience of extra tissue getting caught during intercourse or bunching up in yoga pants and looking like a bulge.
Normal to themselves. And
it's physically uncomfortable for many of our patients who are horseback riders or who spin and do those things a lot too.
Right.
Let alone the psychological impact of it. I cannot tell you how many times we hear from patients that they feel self-conscious during intercourse, even though their partner may assure them that it's not a problem for them. I think most women know a lot of our sexuality is a mental game.
It's our confidence.
And it's how confident you feel in yourself.
Yep.
So even if somebody's telling you, you look perfect, this is fine. Right. If you don't feel that way, then it definitely can translate.
It totally translates on them. And translates on them, just they've mentioned being in a bathing suit on the beach simply, or being in a yoga class, or all those things. It just, when they come in with a valid concern.
Yes.
And by exam, a reason to have the surgery.
Yes.
So I guess.
So when we break things down, there's two ways to kind of look at it. So there's the internal anatomy. So you've got, your vaginal canal and what we call the introitus, which is the entrance of the vaginal canal to the body. So that's kind of looking from the front onward. If you were looking from this angle, you've got your labia majora, which are kind of the outer lips. And you've got the labia minora, which are the inner lips. And I'm a much better surgeon than I am an artist, so don't worry about that. But basically from the front, this is roughly the anatomy. If you're looking kind of in what we call the lithotomy position. These are erasers, aren't they?
No, I think they're magnets.
Oh.
Look at
that. All right. If you're looking kind of what we call the lithotomy or legs up GYN position, then the labia majora tend to be the fuller kind of outer lips. And the labia minora are the lips that are in between.
Right.
And most of the time, they're tucked right between the labia majora.
And then your clitoral is up
clitoral
here.
Hood and the clitoris itself are up here. What happens for women who have excess labia minora, this minora can extend a good 2 inches outside of the labia majora, which is just very uncomfortable for a lot of patients. And a hygiene issue. A lot of patients will get recurrent yeast infections or skin fold infections because of the constant irritation of that skin. Yeah. So that's kind of the terminology. Clitoral hood is the tissue above and around the clitoris towards the top. The labia majora is the kind of fleshier skin that's covered with hair.
Your lips.
Yeah, the outer lips. And then the inner lips, which are usually hairless and usually more like a wet skin texture, are the labia minora.
Mucosa.
So, that's the anatomy lesson. So now that we know what we're talking about, let's talk a little bit about... we've already talked about the why for some patients.
Yeah, I think the thing is a lot of patients who come in are like, oh my gosh, how long has this been around? And, you know, there's unfortunately a lot of doctors who've jumped on the bandwagon, but don't do a lot of these. It's not something a lot of doctors are doing a ton of, and we are doing a lot of these.
Yes.
Our first one was in 2011 or 2010. And I just think that patients being really educated to making the decision of this, because once you take it away, you
and
can't
that's
get it back.
where that Barbie look starts to scare me a little bit. There's this kind of new push on some patients to aesthetically look more ideal by kind of basically amputating the labia completely off. Now, that's a very particular look, but like you said, once you take that all away, you can't put it back. So you want to make sure you're not taking too much tissue below the clitoris so that your clitoris looks like a little penis sticking out.
Exactly.
We've seen that from other surgeons where patients have come in after labiaplasty and nothing has been done to the clitoral hood and everything's removed below and it looks very deformed and weird. So looking for your surgeon's experience is one thing. But I think probably the most common thing that people ask, and something I really do want to go over, is what is normal?
Yeah. Oh no, that is huge. Because it is like, I don't feel normal. Am I normal?
Yes, am I normal is the most common question we get. And here's what I will tell most patients that come in. Most likely, if you're doing this surgery because you want to look better in tight clothes or a bathing suit or feel more comfortable in intercourse, you probably do have normal anatomy. Nothing's wrong with you. There's nothing abnormal about your body parts. But when it comes to how things look, there's always this bell curve. And it's kind of based on averages and standard deviations. Most people tend to fall within the middle section of a bell curve. So they're the average looking. A much smaller percentage of people are kind of what we consider superior or aesthetically ideal. And there's a couple people at the far end of what's considered normal that are almost borderlining on what's abnormal, but it's not really abnormal. I think the problem with this area for women is that as pubic hair grooming has gotten more aggressive and full bikini waxes and airbrushing and magazine photos and all this online public nudity,
it's given
the
a false
people that
sensation.
are here we think of as normal. The aesthetic ideal has become the new normal.
They're the unicorns.
Yes. So all the people that fall into this part of normal now feel like, I'm not normal.
Not normal,
And you are normal.
Right.
So plastic surgery can either be about taking something abnormal and making it normal, or it could be taking something that's normal but less than desirable and making it more ideal.
Right.
And we see a little bit of kind of both of these things from our vaginal rejuvenation patients.
Absolutely.
We have had patients with what's called a rectocele, where you lose the support between the rectum and the vagina from the muscles stretching out during childbirth. And one of our patients referred to what she called a golf ball in the middle of her legs. It was her rectum prolapsing out of her vagina. That's clearly a functional concern. It's not really about being
cosmetic or vain.
Cosmetic or vain. It's about being comfortable and about feeling like your ass is not going to fall out of your vagina. I don't know. I mean,
that's it. That is really truly it. Because a lot of people, I think, have this whole persona that this is all vanity and it's just people trying to be something they're not, and it's not true. Because there's a lot of patients who've come in and they are in this category, and we're like, you know what? You probably shouldn't be doing this. Yeah, exactly.
Just be comfortable with where you are. Do a little laser.
And they just needed that
assurance.
Yeah. So I guess we can kind of dive into how we do the procedures here, because you know, a lot of patients get mixed notions, and a lot of doctors really do this under anesthesia more frequently than we do.
So again, breaking it down, external things, the labia majora, the labia minora, the clitoral hood, we can do under local anesthesia, and I actually prefer to do them under local anesthesia. There's no need to have general anesthesia. It's much more easy for patients to kind of keep their legs in a position where I can really assess how much excess there is from side to side, rather than when people are totally relaxed under anesthesia. If we're doing anything internally with vaginal tightening, we definitely want to do it under anesthesia. You just need it.
And when we do them in the office, it is a completely comfortable environment. And I think patients are shocked like
over
shocked
and over again
by how easy the procedure is, because so many people come in and their like legs are shaking, they're nervous. We've had people cry during a consultation because they feel like they're ashamed or this is not normal, and they walk out the day of the procedure and they're like, oh my god, I would have done that 10 times over again. It's like
how easy it was.
Easier than going to the dentist.
So
it is done under with a local anesthetic.
And we give patients Valium and a pain pill. So you come in, we put on a numbing cream for about an hour. Most of the time people will end up watching Netflix. I wouldn't say seen, because it's always behind me, but I've heard most of Breaking Bad, most of Orange is the New Black, and a lot of Gilmore Girls over the last couple of years, because that seems to be very popular with our patients. But most people just end up getting caught up on an episode or two of a show they like, and they're totally zoned out from what we're actually doing.
Yep. And it's like about an hour to an hour and a half procedure. So that being said, thank you. Sorry. Totally went in my ear.
Yeah. My phone rang, and here we are.
So vaginalplasty.
Yes, vaginalplasty is a little bit of a different animal. So for labiaplasty, most patients will have dissolvable sutures. There's nothing to be removed. They just dissolve over the course of 7 to 10 days. You'll wear a pad. You'll take it easy, meaning be off your feet for 4 or 5 days. No formal exercise for about 2 weeks. Intercourse, you can start to resume about 4 to 6 weeks after surgery. And that is definitely one of those office procedures that you can recover from pretty quickly. We've even had patients that by the second day are taking Tylenol and feel like it was really not that much of a downtime.
Yeah.
Vaginal rejuvenation is a little bit opposite in that you do have general anesthesia, so it takes you a couple days longer to get out of that initial kind of down period. There's not usually too much discomfort. There's not a lot of nerves internally, so people with vaginal rejuvenation often feel very little discomfort. But there's restrictions on heavy lifting and intercourse for about 6 to 8 weeks.
Wouldn't you say it's a lot like kind of the downtime of like somebody who had an ablation done?
Very similar.
Similar,
but with restrictions on lifting, because we're tightening the muscle, and anything you do to exert yourself may undo your sutures and just undo the surgery.
Right.
So if you're putting in all the effort to get it done,
what's the way to know if you need surgery versus maybe a laser tightening?
So laser, I almost don't even want to use the word laser tightening.
Right.
I feel like it's
so that's
more
what I'm trying to
laser
go down that
plumping.
road.
So yes, here's what I would say to patients and what I ask people. If you're satisfied with sex, but your partner is potentially not, either because things aren't as moist as they used to be, or you're not super comfortable during sex, the laser does a great job with slightly uncomfortable vaginal lining, dry vaginal lining. Awesome for people going through menopause. Awesome for women who are early in their 40s who start to have changing hormones. It plumps a little bit. There won't be a huge difference in tightening. So what I would tell people is, if you can, this is going to get very graphic, with a finger internally, if you can Kegel and feel muscle all the way around your finger, this is how I examine in the office,
you're okay.
Then you may not need internal vaginal tightening, and you may see some improvement from Kegeling and the laser. If, however, there's not continuity and you can't feel kind of a ring of muscle between your vagina and your rectum, that's probably been torn during delivery, and there may not be a way to get it back to normal.
To the way it was,
And I will also tell patients sometimes, if it feels like things are loose just at the entrance of the vagina, sometimes we can tighten that muscle externally in the office. If it feels loose all the way up to the cervix, that's an OR case.
Right. Yep.
Other questions, comments?
Now it just makes you want to like start Kegeling.
I know. So it's funny because when we mention the word Kegel, I know everybody's doing it. And it helps with posture.
Awesome. That's awesome. So basically, you can't Kegel a million times to repair something like that.
Yes. So what happens, and this is time for another picture. Melissa loves my pictures.
I do. They're my favorite.
So now we are going to be
totally not winning Pictionary.
So now we're schematically talking about.
She's got.
This is going to be very interesting. This is the vaginal opening. This is the rectum. There is a layer of muscles in between. This is called the perineal body. What happens when somebody has an episiotomy or a vaginal delivery is there's a tear in this muscle. A grade 1 or 2 tear is very small, usually easily repaired, and most people don't notice too much of a difference after.
Right.
A grade 3 or 4 tear can legit go all the way through, like that. Even if it's repaired, You
It's
have
weak.
to imagine that when this is sutured up by the OBGYN, it's not like somebody took a scalpel and made a clean cut through these tissues. They're shredded and torn apart. And it's very difficult to suture them back together and expect them to heal well.
Right.
So a lot of people either are completely missing support, and it makes this vaginal opening look much, much bigger, and there's almost no separation between the vagina and the rectum. Or some people have a thin little strip of muscle that's just not quite what it used to be. If there's just a little strip of muscle, but if we go inside about an inch, we can feel there's better muscle, then we can just tighten at the opening, and that will help strengthen this. If there's no separation, and we can't feel the muscle in the canal, you've got to pull it in from the sides and basically reconstruct that division and that support.
Right. And by doing that, you're rearranging tissue inside there and
it's almost like
more support.
It's very much like a tummy tuck, but inside the vaginal canal. We're lifting up the extra superficial tissue. We're finding the muscles and bringing them back together where they've split apart, and then we take away anything extra on top and suture it back together.
Right. So that kind of covers all that. Okay, what about undoing it? Can you undo it? Can it be if you did something after, had more babies, or...
So if you have another baby, you could undo it. So that suture repair will hold. That muscle may stretch and tear again.
Yeah.
But it may be perfectly fine. Just like we talked about last week with tummy tucks.
Right.
We've had 3 patients who have had tummy tucks and then had babies, and all of them are fine.
Right.
The muscle repair held. So it's possible that for this it could, but I, more strongly than any other surgery, really do encourage people to know they are done having kids before doing this surgery.
And what about, I guess, one other
Labiaplasty doesn't matter, though.
Labiaplasty, yeah. Labiaplasty, well, they don't know that. But yes, labiaplasty.
Labiaplasty, you can have a complete normal pregnancy afterwards. If you're going to tear, some people tear their labia during surgery or during delivery anyway.
Right.
It is a little more likely to tear along one of the previous incisions, but it's definitely not a guarantee, and it's probably somebody who would have torn
to
anyway.
Fix after too.
And it is, yeah.
I guess another misconception, one of the ones patients coming in is like the bladder, weakening of the bladder after having children, or just as you get older in age, patients can have bladder prolapse, and how that plays a role with the vaginal rejuvenation. And we're not urologists.
So there are basically 4 parts of the vaginal canal. There's the front part that goes up against the bladder, the back part that goes against the rectum, and the sides. I tighten along the sides and the back. I do not tighten along the top where the bladder is. Like you said, I'm not a urologist. That's not the goal of my surgery. There are suspension procedures and formal procedures covered by insurance that are better if,
that's an issue.
Urinary incontinence is your main concern.
Right.
Many of our patients have a little vaginal laxity and a little incontinence, but they're not going to go having a major surgery. They don't want to mesh, and that's where the vaginal laser can also come in and do a really nice job. Our nurse practitioner, Katie, does those, and she has several patients that now come in once every 6 months or so just for a little touch-up treatment, and it keeps their incontinence under control.
And it's just a 10-minute procedure, and it's no downtime besides, about, I think, 24 to 48 hours of no intercourse.
Yes. I have had the internal laser done. Yeah. I try almost everything we have this practice just to make sure I know what it's going to feel like and what it does and doesn't do. And I will tell you, it felt very much like absolutely nothing getting it done.
Yeah.
I kept bracing myself ready for something, and there was nothing. So that part was very easy. And then for the next couple of days, it was just mildly irritated, uncomfortable, but I worked and I took care of the kids and I didn't take anything.
Do anything else,
So
it's
that's just more annoying
for
than anything.
Sexual improvement with moisture and bladder support, but not really the full tightening. That's kind of clear
Correct.
out.
Correct. So yes, I would say vaginal laser is for urinary incontinence, moisture, slight plumping. Vaginal surgery is more for tightening, and getting things back to the way they felt before kids.
And the labiaplasty is for external,
issues.
So,
a little bit about labia majora. Don't want to leave labia majora.
Oh yeah.
Some patients will come in complaining about looseness in the outer lips, and this is a tricky territory for me. Deflation, where they just seem wrinkly and deflated. So there are a few things we can do to the outer lips. We can remove skin, but it works better for some patients than others, because if you have a very large labia minora and a loose deflated labia majora, taking away that majora skin is just going to make the minora look bigger.
Prominent.
And a lot of our patients who want extra tissue removed in the area, it's because they want things to look smaller.
Right.
So when we plump up with fat or do something to reduce wrinkles, some people feel like it's just trading one problem for another.
Yep. That's a tricky one.
It is a tricky one.
Yeah.
So I tread lightly when it comes to the labia majora. I will do some skin resection. I will do some laser to kind of reduce wrinkling. I will do some mild plumping with fat, but I that's one where I really want to talk to a patient individually.
We don't get a lot of inquiries for that as much as the menorah.
No, but we do get some. They're concerned about both.
Right.
And those are the things that go through my head when I'm kind of talking to those patients.
Yeah.
I have a question. Is age a factor in getting a labiaplasty?
It's a great question.
Well,
so the
puberty
times,
does.
Yeah, the times in women's lives where this kind of growth tends to happen tend to be right during or after puberty. Some women notice some changes in their 20s or 30s associated with pregnancies or birth control.
Right.
And then a lot of women notice changes after menopause. So it's clearly very hormonally mediated.
Right. Yep.
I have had a boatload of patients that are about 15 or 16 years old. They're mature with sexual development. They've had their period for several years. This tissue's not going away.
No.
It's not getting better. And it can be doubly traumatic for a teenager who feels very different than her friends in a bathing suit in a locker room. So I have done several patients who are 15, 16 years old. My youngest patient was 12.
Yeah.
And
understand when we're saying that too. It's not just that 12-year-old.
These are not
these are not your typical.
Yeah.
These are very deformities. Like,
well, and I remember the patient, the 12-year-old mother was a patient of ours, and I said, she asked me about it, and I said, well, I'm happy to talk to you about it, but I can pretty much promise you I'm not going to do it at her age.
Right.
But when I saw her and heard about the fact that it had already looked like this for 3 years, and it was a significant amount of tissue, we talked about all the pros and cons and agreed to do it. And she had a great outcome, and she's perfectly happy.
Yeah.
A lot of people worry about risk of sensation loss. There's almost no risk of sensation loss when this procedure is done correctly. The nerves to that tissue come from way deep underneath, and we're working very superficially. So if you go to somebody who knows what they're doing, there's almost zero risk of change in sensation at all.
Absolutely. But yeah, it is definitely. It's not a huge factor on the issue, but definitely it plays a part with making sure that you have had your period and
emotional maturity and development,
support from parents,
absolutely,
things like that. Absolutely needs to be done. But if the younger they are, it is more.
It's more emotional.
But I would say we don't do a lot of young patients.
No.
Really, if it's medically necessary.
Absolutely. The majority of our patients are somewhere in their mid to late 20s. Or there's another huge group that's in kind of their 40s that are doing this after their kids are grown and they kind of feel like it's their time to do something for them.
Yeah. Okay. That's that. So that is that topic.
All right.
Enjoy
Cheers,
your water.
Cheers, everyone. Animals from my body.
Dr. Goldberg's off to surgery now, so.